All right, I know there's only a few folks, but like I said, realize there's a lot going on right now. There's folks who are sick, there are folks out of the office, there's a lot happening with the legislature. So I think we'll maybe just get ourselves started and hopefully folks will kind of trickle in to join the meeting today. Thanks to those of you who are able to join us. I apologize again to advisory council members for not sending the slides out further in advance, but I did send them out maybe about 30 minutes ago. So for those of you who would like to, have them open, be able to review kind of on your own time as we're going through them, they should be in your inboxes, and no expectation at all that folks reviewed those in advance. I think this is very much a kind of sharing an update on some research and thinking that we've done more than a decision-making meeting. It's trying to set up a bit of a conversation, I think, for our next meeting in March. So with that being said, I will jump right into the agenda slide. I can get it working. I wanted to start out just with one item that's not on the agenda, but just to kind of acknowledge, I think, the challenges that many folks are facing right now, given some of the uncertainty and kind of seismic shifts happening at the federal level in particular. Having seen news yesterday that there are providers in the state of Maine that are struggling with accessing critical federal funding and dealing with sort of impacts of that on operation. I just wanted to acknowledge it. It feels strange to me that jump in and talk about this sort of forward-looking work when there's really critical challenges like that on the forefront for many. And to say, I think we're monitoring that in the Office of Affordable Healthcare, thinking about how we can be helpful and welcome feedback from members of the Advisory Council about work that we can do, or if there's data that we can provide or support that sort of helps with that. But in the meantime, we are trying to continue our work and continue the sort of forward-facing thinking about how we can improve the healthcare system. But again, like I said, just wanted to take a note or a moment to take note of that and say that we're continuing to keep an eye on things. And if there are significant shifts, that may mean that in the months or years ahead, we kind of change our focus and may think more about ways that we can be a little bit more involved in those conversations, given the impact. But for today, kind of sticking to the agenda that we had planned and moving forward through that. So to start off, just a couple of administrative items that we wanted to touch on. The first is just a reminder on the adjustment to meeting dates. So we had a member of the Advisory Council who had a standing, ongoing, consistent conflict with these meetings on the first Wednesday in the even months. So we'd sent around a note about that. We have now made the change to switch to odd months to accommodate that member. Realize no timing is perfect, and there's some challenges around that, especially with weeks that might be short for holidays, but we felt like that would be the least disruptive way to try to ensure that we had as much participation and attendance at meetings as possible. So like I said, Kaylee, I think, sent out that new meeting series, so it should be reflected on all your calendars now, but just a note, so in case that got lost in the email shuffle, it would be top of mind for folks. The other administrative update I wanted to share was just about vacancies on the Advisory Council. We've had a somewhat long-standing vacancy. We had to have someone step down, Carl Toney, who was in the seat representing the interests of older Mainers. And more recently, Christy Daggett needed to step down from her role on the Advisory Council. So that's a couple of seats that are vacant. Now that there's a new leadership on the Senate and House side, I've been in touch with both of those offices, and both the vacancies are Senate appointments. So made them aware of that, and we'll be working with them on a process for nominations and to fill those seats. And alongside that, actually, given that the terms of current members were initial terms and are designed to be staggered, although they were never actually assigned staggered end dates at the time that folks were appointed, there is a need to do renominations for some of the seats for full 5-year terms moving forward. So that's also a process that we're working with legislative leadership to try and take care of this session, so that we kind of have things all tidied up and clear term dates for all members. So just a heads up on that, to be on the lookout, and please let us know if you have questions or concerns about any of that. Happy to chat about it. But otherwise, I would imagine most of that communication will come from those leadership offices that ultimately make the nominations and shepherd them through the process. But we're just trying to support as much as possible with that, because they have many of them to do for many different bodies, and we kind of want to advocate for this council and the needs. So those are just a couple of kind of House business items I wanted to take care of off the top. Any questions on either of those before we move into the more substantive part of the agenda? Okay, great. So moving on, we wanted to do kind of a deep dive on a particular topic for today's meeting, which is one of the policy domains that we had talked about in our meetings towards the end of 2024, particularly thinking about private equity and financialization in healthcare. So just as a reminder, this was one of those 3 domains that we identified and kind of agreed during the last meeting that the office would focus on for 2025. And we'd written out this problem statement about kind of the role of private equity investment in healthcare, some of the risks that poses, and saying, that we would come away, review and assess options for mitigating risk from PE acquisition, including efforts in other states. So this presentation is really sort of our report back on that next step for all of you. So to start off, as I've been doing a lot more sort of reading and immersing myself in this topic, one thing that's been interesting for me in terms of kind of conceptualizing the issue and discussing it is thinking about the broader issue than just private equity, which is really financialization in the healthcare system, and meaning financialization, meaning the transformation of public, private, and corporate healthcare entities into saleable and tradable assets from which the financial sector may accumulate capital. That's a technical definition I've pulled from some literature on this topic, but I think my characterization of that is really this shift, not necessarily dependent on corporatization per se. It's not so much about the specific entity involved in the healthcare segment or provider organization, but this shift from thinking about the value of the healthcare provider or system or entity being inherently tied to the services that it's providing and sort of the work that it does and the work that it produces. And yes, there's a financial component to that because revenue is dependent on that, but the two things are really tied together, that revenue is coming and hopefully increasing based on the value that the entity provides to its community in terms of healthcare services. And financialization, meaning this real shift to thinking about healthcare entities as truly sort of means of generating capital and much more like pure financial assets. And a shift away too, again, from revenue coming from the work that those systems are doing to provide healthcare and to financial investment arms and financial components of the broader system, these saleable and tradable assets. So private equity, is still definitely a focus, and I think has been considered the farthest extension of financialization in healthcare, particularly because some of the components that are unique or specific to private equity, that it's really specifically focused on short-term return on investment, and because firms are utilizing other parties' capital in their investments, so they're not actually as concerned about losses as other types of investment vehicles are, where investors are the ones controlling decisions and will lose money if there's a loss in terms of the final kind of outcome of the entity that's purchased. So that's just a little bit of a setup, I think. We'll still talk a lot specifically about private equity here because I think it has been a focus of a lot of the research in this space, but just wanted to set it up because I think as we move into discussion about solutions here, thinking about how solutions apply to financialization can be helpful instead of just thinking about private equity firms specifically, and kind of like addressing the concerns and the behavior rather than the specific financial structure of a given entity involved in a transaction. So Katie's been doing some work looking at the literature on this topic, which there's some great recent developments on. So I'm going to hand it off to her to kind of do just a walkthrough of some of her findings.
Absolutely. Thank you, Meg, and good afternoon to you all. As Meg said, there's more research coming in about the impact of private equity in the healthcare sector and space. To start, there was a recent study conducted in 2024 that tried to quantify the penetration of private equity in the healthcare setting. And Exhibit 2 or Figure 2 on the left shows private equity penetration at the physician level in the US across different specialties. And something to take away here, between 2012 and 2021, there's an increase across all specialties of private equity acquisition at the physician level, but specifically there is increased attention to specific specialties, gastroenterology, dermatology, and urology being a few. But there has been increases in private equity acquisition across this time, across all of the specialties. This study also estimated that in 2012, there was roughly 816 private equity physician practices, and that by 2021, that number increased to just under 6,000. And that in 2024, there's an estimated 460 hospitals owned by private equity, and this makes up about 22% of for-profit hospitals and about 8% of all non-government or non-government owned hospitals. And the Department of Health and Human Services early last month came out with a helpful review of the literature on private equity and the impact on things like spending and healthcare quality. That paper, one of the main takeaways was that there is more research to come, but I'm happy to highlight some of the larger takeaways and studies in that report. One of them being a study done by Singh and colleagues in 2022. The study looked at private equity ownership and the association on spending at the physician practice level. And what they found in Figure 1, when you compare physician practices that are owned by private equity groups compared to physician practices that are not owned by private equity, after private equity acquisition, there is an increased spending in total spending among these practices. And that increase in spending, they tracked over the course of 2 years after the acquisition. That vertical line at the 0 mark marks the time of acquisition, and afterward is comparing dollars spent per practice among private equity-owned physician practices to dollars spent per practice among those not owned by private equity firms. They also found in this paper that these increases in spending among private equity practices could be attributed to higher prices. That was found to be not only that there were more charges associated with an episode of care, but also that the allowed amounts per claim were increased in the private equity firms compared to those owned not in private equity. They also found increased utilization among these groups as well, where among private equity owned physician practices, there were increases in the number of new patients as well as the number of established patient visits over the course of a year.
A sense of where that spending was located? I mean, like, right, there could be good spending on the delivery system side if it's investments that improve outcomes, but did this study look into how they were spending that money?
I can look back and see they didn't report that in their major findings. They did look at just a 2-year time span, so I'm not sure if they followed up on some long-term investments or things like that, but I'm happy to look into that and see.
Great, thank you.
So outside of physician practices, there also have been studies that have looked at the impact of private equity ownership in hospitals and spending. There are 2 major studies in this space that found that among private equity owned hospitals, there are increased charges in cost to charge ratios. And these were associated with lower Medicare patient admittance among these groups as well, or these private equity owned hospitals, and lower salary expenditures, especially for ED and ICU personnel. And one of the takeaways from this, the larger report by the U.S. Department of Health and Human Services, was that among private equity groups they had seen ownership of private equity resulted in both increased charges, but decrease in costs, and most of the driving decrease of costs being in lower salary expenditures. And the difference in Medicare patient ratios, where less Medicare admittance resulted in less complex patients and lower costs. And then finally, there have been several studies, though I'll note that it's early literature right now, and there isn't large consensus related to private equity ownership and quality of care in different healthcare settings. But among 3 papers, there has been some trends that in nursing homes, there was an indicated or a observed increase in short-term mortality of Medicare patients in private equity-owned nursing homes compared to nursing homes not owned by private equity firms. They also, in these papers, found decline in nursing ratio staff and compliance with care standards, and lower CMS quality star ratings associated with those non-compliance of care standards. In the hospital setting, there have been reported increased hospital-acquired adverse events, including slips and trips and falls, as well as hospital-acquired infections like central line infections and others. These have been coupled with declines in patient-reported experience measures at the hospital level. Now, I do want to note there are some papers out there that show or report increased quality among private equity-owned hospitals, and criticisms around these reports is that they haven't taken into account lower Medicare admission after acquisition. So there is, I would say, a growing body of literature that's suggesting lower quality of care, but it's still early literature and something that we will continue to look out for in the future.
Thank you, Katie. Welcome questions on that, and we'll just reinforce Katie's point. I think it gets to your question a little bit, Trevor, which is, I don't think that we would say, there is a monolith and private equity investment is always problematic. I'm sure that there are cases where, private equity has come in and maybe been able to increase efficiency or increase quality. But I think the findings so far suggest that there's reason for concern broadly. And I think that ties to, again, the specific structural concerns around private equity, which are that these aren't entities that are coming in and saying, we're going to increase the efficiency of, let's say, a hospital, and then over the long term, we will reap the benefits of that efficiency. They are coming in and wanting to make a profit on a quick turnaround, and then generally the way to do that tends to be things like cutting staffing, cutting salaries, upcoding, kind of actions like that.
Is there any research on sort of the broader market impacts? I would assume as private equity comes into a market, they're picking really the highest margin service lines that they're going to focus on, or highest profit, which is going to obviously take that care out of hospital settings, causing deficit where they have to rearrange or cut potentially other service lines. So just curious, sort of like, is anyone taking like the macro view of what private equity is doing in the market?
Absolutely. I think this, and I'm happy to share the report by the U.S. Department of Health and Human Services. They looked at larger impact of consolidation in the market and then the spotlight on private equity and seeing what that could be doing to competition of services in those areas. Their takeaway was that, and I can go back and get further information for you, but I would say their takeaway was that the research still needs to come out on some of those impacts, but that there is a concerning share of the market for some of these, consolidated or specialty care services in geographical locations impacting the greater market around it.
Yeah, what I was just going to say, it might be that we are both thinking of the same section of that report, which I will just say is a great read for anyone. I think it just came out right at the end of the year, or maybe even early this year. The federal HHS had done a request for information. So this is a paper summarizing the responses to that includes some research, but also anecdotal kind of stories of the impact. And just one thing was definitely that the evidence supports that they're going after specialty practices that are higher margin. So there's that evidence, the piece about what's the broader impact. I don't think
at a certain point, you don't even need to study to know that private equity is going to go after wherever the most money is.
Yeah. So moving on that point, we kind of wanted to do a little case study moment. I think I've mentioned in the abstract quickly in some of the previous meetings, this situation that occurred with Steward Healthcare. A lot of the attention around it was focused on Massachusetts because that's where some of the most significant impact was, although it is broader. And to speak about it a little bit, just because I think it's a helpful illustration of what can happen and some of the particular risks that are posed by private equity models and some of the kind of financial maneuvers that they make. So wanted to go through kind of a brief summary of the timeline here. Really, things began in 2010. Steward, which is this private equity-backed health system, got its start buying 6 hospitals. They were struggling hospitals in the greater Boston area, so they were not in a strong financial position at the time that they were purchased. I think, you know, the questions there are mixed, especially when it comes to hospital acquisition, because the struggling ones may, you know, appear a bargain at the time of purchase, or there may not be a significant interest from other parties in purchasing them that can allow private equity to kind of swoop in and acquire them. As part of the acquisition, they transitioned the hospitals from nonprofit to for-profit status. There was Attorney General involvement and some review of that process and discussion. So as part of the transaction process, the firm had promised that they were going to keep the hospitals open. They had promised hundreds of millions, if not $1 billion in new investments in infrastructure, said they were going to come in and improve quality, and promised expanded service lines as well. Following that initial sort of transaction to purchase this group of hospitals in Boston, the firm continued expanding, and they started buying hospitals and physician practices around the country. Eventually, they have 33 hospitals, 25 urgent care, 107 skilled nursing facilities, and then a large number of physician practices, though I couldn't find a number of exactly how many. The firm then between 2016 and 2020 continued to be unprofitable, and it was sort of leveraging debt on the hospitals it owned to buy more, presumably in the hopes of becoming profitable at some point, but that did not happen. The firm, as I said, leveraged assets to continue expansion, and one of the features or the factors in this process that I think has gotten a lot of attention and focus is that the system sold its hospital properties to a third-party real estate investment trust and then leased the properties back as a way of generating a large amount of revenue to continue expansion, but putting the hospitals in a situation where they lost much of their sort of true inherent value and were stuck in contracts needing to pay rent to this large real estate investment trust. In 2020, the private equity firm transferred ownership of the system to a hospital management group led by the existing CEO of the system, making $100 million for investors in the firm as part of that transaction, and the CEO himself being paid an $111 million dividend. So lots of focus on that individual in scrutiny of what happened here, because then very quickly, the financial struggles continued. The system filed for bankruptcy in 2024, and suddenly states were being faced with being told that, hospitals, some of them in really critical areas where there were not options for other health services, were going to be closed. So states had to step in. In Massachusetts, I think the state was pretty involved in trying to facilitate transfer of ownership, and they were able to do that with 5 of the hospitals where well-established systems in the state stepped in and took them on. But 2 closed because they could not find buyers for them, somewhat understandably given the financial position they were in. And in far western Pennsylvania, there was a regional medical center, again, that was really critical for the community. And the state paid $4.5 million over a 3-month period to help keep that open. I believe they were able to transfer ownership eventually, but because they felt that it was so critical to allow consumers to still have access to that facility. So those are just a few examples. There are other instances of states needing to get involved and of other consequences around the country. But that sale leaseback arrangement, we know that hospitals can struggle and there can be challenges, but decisions like that, are really an example. And then the transfer of ownership and sort of the profit that was made, even while the hospitals themselves were struggling so much financially and were losing much of their value is really sort of, I think, what sets apart this issue of financialization and the risk that is presented. And I will say particularly interesting to see this happen in a state like Massachusetts that's often looked to as really the model in terms of transparency and oversight of its healthcare system. The state did have ability to get notice of transactions and had some requirements around financial reporting for hospitals that Stewart did not comply with, and there was a drawn out legal process over that. But I think just kind of a learning in terms of the limits of what transparency can do without authority here. So Massachusetts is actually in the sort of fallout from this, taken some action just in the last few months on this front that we'll get into in the next section, where we wanted to talk more about what can be done now that we've outlined the problem a little bit. But I will pause there in case there's any questions. So moving along, we wanted to, take those learnings. I think we felt that, not surprisingly, after the conversations and continuing to dig in and learn, that this is an area where we think that there's opportunity and that it may be useful for the state of Maine to take proactive action. As we've said before, it's difficult actually to understand the penetration of private equity into specific states because there isn't sort of uniform data collection around that or sources of data. We know there's limited penetration at the hospital level, some at the nursing home level in the state, but particularly independent provider practices are a little bit more challenging. But by and large, I'd say Maine is one of the states where there's less private equity activity right now than in many other parts of the country. So it's sort of a moment when there's some ability to think about protecting that and trying to continue that. But it's a challenge, I think, because it is such a nuanced issue, that this isn't as simple as saying private equity is bad, no private equity, because there might be situations where a turnaround is needed and maybe a firm can come in. So we tried to think about that in thinking about the policy options available in this area. And based on kind of reviewing papers on this topic, looking at what other states are doing, kind of felt like there were 4 possibilities or 4 different approaches for addressing financialization. The first is the transparency component. Lots of states have or are taking action in this area, thinking about increased notice or reporting requirements and greater kind of publication or availability of that data. I think there's, as I said, limitations there, just because we haven't seen that necessarily be immediately effective in terms of changing behavior or stemming the tide. I think it's mostly helpful in terms of these conversations and understanding the scope and impact of the issue. Corporate practice of medicine statutes prohibit corporations from owning medical practices. We're a little bit of an outlier in Maine in that we do not have a corporate practice of medicine statute. More than half of other states do have these provisions. I think they found them often challenging to enforce. Private equity entities or other kind of corporate actors can hire physicians and make physicians, technically the owner of a practice with sort of favorable management contracts, but then, truly control of business operations may not be completely at their discretion. So there is some work in states that have these statutes around strengthening those. I think based on our review, we felt like creating a corporate practice of medicine statute in the state of Maine, given that we do not have an existing one, could potentially be disruptive. And there may be, small practices with certain ownership structures where a physician is not themselves technically the owner of a practice that there could sort of be unintended consequences and broader consequences than what's really intended here. So that combined with concerns about how strongly these can be implemented and the ability of financial firms to find ways to work around laws, made us less interested in that approach. Papers, particularly, some of the academic work on this has discussed kind of getting at the root issue here, which are incentives for financialization, thinking about reducing the appeal of corporate involvement or financial firm involvement by capping or regulating prices for healthcare services, which can reduce, that ability to make a quick turnaround. I think that would address part of the problem, but not all of it in these cases, just looking at some of the models that these entities have used, or the example of Steward, for example. So some limitations there, and then obviously that's a much broader conversation that has much broader impacts than simply thinking about protective measures. So then the final category is transaction review, probably where the most, I think, interest and kind of action from states has been in the last year or so, which is really about empowering a state agency to review healthcare transactions and approve, deny, or impose conditions on those based on a variety of considerations. I'm thinking about access, affordability, health equity, and others. And we're going to talk a little bit more about that because I think in our review, thinking about these models, the idea of transaction review is the one that we felt had the most promise in Maine. It feels like it is, targeted enough to be really thinking about the kind of issues and behavior at play here and what we've discussed as wanting to address, but also flexible enough that it allows for the kind of nuance to actually sort of address problematic actors without shutting the state's door on kind of all financial involvement from financial entities or for-profit organizations, which may be necessary in some cases. So just briefly, NASHP has done a lot of work on this front. So thanks to them for helping with sort of putting this together in the sense of the materials that they have available. We grabbed this chart from some work that they have done on existing state laws on that allow for review of changes in ownership for healthcare related entities. You can see here it's sort of a increasing degree of responsibility and oversight as you move down the activity section on the left-hand side, starting with just providing notice of transaction. Some states have notice and are allowed to review the transaction and may refer it out to an attorney general's office for consideration, but don't have authority to approve or deny the transactions. Second from the bottom is that authority to approve or deny. And then finally, the smallest subset of states also have ability to monitor compliance with the terms of the transaction that are applied if they have approved it. I think thinking about this chart, and I should say moving across from left to right, it's sort of the application. So the largest number of states have this kind of review for nonprofit provider entities. Some have it for for-profit providers, a much smaller subset for insurance carriers. And then there's separate review for other healthcare entities. I do think that sort of one note on this chart is it comprises a broad range of types of review activity, including, I think, attorney general ability to review for antitrust transactions, or in that nonprofit column, compliance with state laws around nonprofit structures. So I think it's fair to say, and I don't think many of these states would argue, that many of the states that are listed here have some level of oversight, but probably not enough that they can sort of effectively block or be involved in or set conditions on the majority of the kinds of transactions we're talking about. I think a couple of the limitations there are the size of the transaction. So oftentimes thinking about this issue from an antitrust perspective, there can be quite high dollar amounts associated with either the entities involved in the transaction or the size of the transaction itself that exempt things like a private equity firm coming in and buying up one specialty practice and then 1 year later or 6 months later buying another specialty practice, in that process of kind of rolling up and consolidating control over a specialty in a given geographic area is sort of in the playbook of what they have been known to do. So that's a significant challenge. And then the other is often about the type of entity that is included. Oftentimes these statutes, and I think it's really just a function of kind of different times from when they were written or designed, are focused specifically on provider entities and really thinking about a scenario where two hospitals are merging, or one hospital is buying a provider practice, for example, but don't necessarily speak to or contemplate the involvement of a non-provider financial entity, either taking control of a provider or taking control of a segment of a provider's operations, for example. So I say that only to say lots of activity on this, but not necessarily, I don't want this chart to imply, oh, most other states have kind of solved this problem and Maine hasn't. I think it's one that states are really working on. So to that end, we actually wanted to focus on, I really think there's 2 states at this point that have taken action that folks feel has potential to be impactful in thinking about kind of addressing the financialization issue. The first, which I referenced earlier, was Massachusetts. So, they may have been contemplating it before, but from all I heard, I think the Steward situation in particular for their elected officials really motivated them to want to figure out sort of what went wrong and how could they prevent a similar situation from happening in the future. So they built on a structure they already had. So they already required the submission or the notice of material change transactions to their Health Policy Commission and also the Attorney General's office and their health analytics body, but really it's the Health Policy Commission that I think takes the lead on these issues. But so the entity, the Health Policy Commission, got notice, but didn't have really a review process or much ability to do anything about transactions that were concerning to them. So this law, which was just signed at the beginning of the year, it happened very sort of like last minute in the end of their session in December, after I think a lot of work with stakeholders around the details, broaden the definition of material change transaction to include significant equity investors. So getting at that issue that I mentioned before of there not really being language under prior statute to capture some of these non-provider entities that may be involved in healthcare transactions. It specifically includes nonprofit to for-profit conversions, even without change of ownership, and significant acquisition, sale, or transfer of assets. So again, it wouldn't need to be a change in the entire, the ownership of an entire entity. They can take a look at sort of smaller subset transactions. It also empowers the Health Policy Commission to perform cost and market impact review if it identifies that a transaction has risk of reducing competition or increasing spending, specifically increasing spending in a way that would cause the entity to exceed the caps that they have in the state for healthcare spending. And they are able to refer the results of the review to the Attorney General for action. So this statute does stop short of allowing the Health Policy Commission themselves to deny a transaction, but creates a much more structured and specific set of requirements for the review to empower the Attorney General to take action. It does a couple other things as well. The law requires annual financial reporting for entities, really pretty large entities, I think exceeding 15,000 patients or revenue over, I believe it's 25 million, and allows for penalties to be assessed for non-compliance with that financial reporting. And finally amends their False Claims Act in the state to make ownership or investment interests liable if a person or entity held by that ownership or investment interest violates the law. The other example we wanted to point to of this work in another state is Oregon's Healthcare Market Oversight Program. We had discussed really briefly this program back when Maureen came to present to the group earlier in 2024, but hadn't had a chance to deep dive too much. So we've spent a lot more time kind of getting acquainted with their structure and process. The program was created in 2021 and really stood up and began its activities in 2022 and is directed to review transactions involving healthcare entities relatively broadly defined within the state. So the the Oregon Health Authority, reviews proposed transactions to see how they can affect market consolidation, competition, access to care, quality, pretty broad set of factors that they are permitted to consider in their review. And they can make a decision to just sort of provide an approval in a pretty preliminary way, or to require that a transaction undergo a comprehensive review if from the preliminary review they identify risk to any of those kind of domains or areas. Under the review, or to be subject to the review, there are thresholds to kind of ensure that they're not capturing small provider to provider or very small practice transactions. So at least one of the entities in a transaction must have revenue that exceeds $25 million, and the other has to exceed $10 million. So, if it's a large entity buying a very small one, that would be exempted, or two mid-size entities, mid-size all being relative when we're talking about healthcare costs and revenue. But trying to sort of capture transactions large enough that they're likely to have, I think, significant impacts on the state. And the law includes some exemptions as well. So new clinical affiliations are exempted, transactions involving FQHCs are, as well as restructures to kind of corporate structure that don't impact the actual control of the entity. This program's been operating for a little while now, and they've conducted review of 29 transactions that they were noticed, and 5 comprehensive reviews. So far, the program hasn't denied any transactions. They have provided immediate or pretty quick approval of several, and 10 of them were approved along with conditions. One of those that I saw was Amazon purchased One Medical Group, a primary care provider that has a presence in Oregon, though it's a limited presence. So I think that was part of the consideration that the group or the organization applied, was that the reach and sort of the number of patients impacted were not high, but they did place conditions on the transaction requiring ongoing submittal of quality information and patient information as well, number of patients being served by the practices, for example, before they were willing to approve that transaction. And just as a matter of interest, 6 of the transactions that were reviewed through this program involved a private equity firm. I'm just running along, so feel free to raise hands if anybody who's online would like me to pause or has questions. Having taken a look at that work in other states, and as I said, really identifying the transaction oversight as the area that we felt, or the policy area that we felt had the most promise, we took a look around, and NASHP has created model legislation that I think really has taken learnings from the Oregon experience and from Massachusetts experience in the design of their law to put together something that states can consider adopting and working on themselves. That model legislation has 3 main parts. The first is a material change transaction review process. So really just requirements and structure for the 2 programs that we talked about, Massachusetts and Oregon having. It's a very comprehensive approach to that process. So for example, the definition of healthcare entity in the model legislation includes providers as well as PBMs and insurers, and allows for a very broad section or type of transactions to be reviewed, but provides a helpful framework for kind of design of such a program. Part 2 proposes refinements to corporate practice of medicine laws to increase their effectiveness. As I said before, states that have those have been wanting to see what they can do to make them more enforceable. And then part 3 is a transparency section that requires annual data reporting, of organizational structure for healthcare entities using a similar definition as part 1. As well as some financial data. And I just put the link for those who are interested to the full model legislation on NASHP's website. So we have been thinking about the application of this model legislation potentially to Maine, and having had conversations with a few different legislators just in sort of the first weeks of January in session, there seems to be some interest around pursuing a model like this for the state of Maine. I think given some of the changes at the state level that are happening and some of the sort of news around hospitals in the state of Maine, I think there may likely be some energy and some interest from legislators in this session. So we did work with Dr. Sam Zager, Representative Sam Zager, to put in a draft of legislation based on this NASHP model, just to make sure that there is a vehicle to work with during this session. I think we didn't want to miss, the boat on cloture. If there's some interest in working on this, but are still very much kind of having conversations about the exact structure and what this could look like for the state of Maine. So wanted to preview that, and I'll talk through a few considerations and things that we're thinking about, but then the hope is to have a draft of that to share with advisory council members as well, to gather some input and potentially hopefully do that even before there's language that is printed for the bill. And we've been thinking again about applications specific to Maine. So a few thoughts we've had as you take a look at this if you're interested. The first is the breadth of that definition of a healthcare entity in part 1 of the legislation. Given that we actually have a PBM licensure law in the state of Maine, and that authority falls within the Bureau of Insurance, and also the Bureau of Insurance itself has material change transaction notice requirements for carriers. Our thinking would be to avoid kind of duplication of processes, to think about narrowing down a change transaction review process to focus more on provider entities where there's sort of less of an existing infrastructure and less complication about trying to run those reviews for very different types of entities. The other is thinking about the structure for a model like this and sort of integration or work with current state law. So I maybe should have mentioned on the slide about models in other states or other states where there are laws on the books on transaction oversight. Certificate of need laws are exempted from that. I think they are a category of their own and already complex and probably too much to summarize on one single table, but Maine does have certificate of need review for transfers of ownership and some other very high level transactions in the healthcare system in the state of Maine. So we would think it would be worth contemplating, changes to avoid duplication of processes, to maybe think about kind of expanding or modernizing that statute to be more responsive and flexible for kind of the status of today's market versus maybe when that law was originally drafted or last amended, because I know it's been amended many times. So that's sort of what we would contemplate, again, wanting to make sure that there are not conflicting or separate processes for kind of similarly intended review where there would be overlap in the considerations in a decision, and also really to kind of leverage existing structures. A major component that we would think about, I think I mentioned before, that given that Maine doesn't have a corporate practice of medicine law, we wouldn't see value necessarily, or don't feel that it would be worth the effort to put into trying to create a corporate practice of medicine statute in the state, given that could have broad impacts and unintended impacts to kind of current operation of practices and provision of healthcare in the state. So we'd propose really focusing on part 1 and part 3 of this NASHP model rather than part 2.
What is the example? What do those laws look like? What do they do? Corporate practice of medicine laws?
They really basically say only a licensed medical professional can own a medical practice, that a corporate entity cannot be the owner of a medical practice. But again, I think realities about ownership versus decision-making are hard to legislate. Happy to kind of do a deeper dive on that at some point too, but that's my basic understanding. Part 3, I do think in the state, but I do also think that we are ahead of the curve on that, in that there's already submission of financial data to the Maine Health Data Organization, specifically in the form of audited financial statements. from hospitals. So our thinking on that after sort of some discussion and consideration would be to think about the organizational structure piece, which I do think is a gap that we have right now. I know we found that based on some of our prior conversations, as we've said, we've been trying to better understand sort of getting a handle on costs and how costs relate to spending or prices at hospitals, and trying to do that at an aggregate level without being able to really understand what are the various entities within a health system, which are nonprofit, which are for-profit, how do they sort of relate to each other, can be really challenging. So I think that greater data collection would be really helpful for that purpose, and also just in getting a better sense of what's happening, again, at a kind of smaller provider level across the state. As we've said, a challenge here, and I think it's come up in prior meetings, we've sometimes talked about the trend of kind of consolidation or health system ownership of providers, but there's not like a longitudinal data set that allows us to say, yes, we can see that at this time there were this many independent providers and now there are fewer, and here's who they've been acquired by. So this data collection would include some exemptions for really small provider entities. So just, a single kind of self-employed physician or a very small practice wouldn't necessarily need to submit, but it would give us a little bit of a better sense of sort of who is out there over time and allow us to draw some conclusions and track that. So that is kind of an update on that front. As I said, I know this is a lot and it's sort of something that we've tried to pull together somewhat quickly to be kind of responsive to what's happening around the state and interest from the legislature, but also kind of consistent with the conversations we've had up to this point. So just sort of wanted to briefly talk next steps. As I said, we've been trying to put this together into legislative language and get a sense, especially within state government, of folks who would be impacted, sort of their review and their input. But obviously want the advisory council's feedback as part of that process as well. So what we propose is, sharing a draft sometime, I would think, in the next week or two. I think we'll have that and be able to send it around. And given that we've had a shift in the meeting schedule and now have a meeting in just 1 month's time instead of 2 months' time, and given timelines for drafting of bills, because I know there are many, I think we'll have time that we can do sort of an in-depth discussion of the legislation and get feedback and kind of dive more into the details and thoughts from the group at the March meeting at the very beginning of March. So that was a lot. I will pause there and see if folks have, initial reactions. I think certainly if there are immediate gut reactions, we'd love to hear those now, or questions on any of this. Any feedback?
I mean, I think this is important to have something like this. We don't know what we don't know, and there's really no oversight currently, or people tracking these potentially profit-seeking entities coming into the state and disrupting the market dynamics here. And to the degree we want to allow them to come in, we don't want to see a repeat of the Steward situation here in Maine. So, it makes a lot of sense to me.
Thank you. Appreciate that.
Yeah, this is Mallory. I would totally agree. I have just personally major issues, or philosophically major issues, with for-profitness within healthcare in general. Being that it is more of a public good that should be based on a nonprofit incentive versus a profit incentive, I think having some sort of oversight and tracking mechanisms would be really important to put in place, in advance of issues arising.
Thank you, Mallory.
And not that some issues have not already arisen in the state of Maine, actually, but I think this would be really important.
Yeah, I hear you. Before crisis point, it was really eye-opening, I think, for me, watching what occurred in Massachusetts and just thinking about being in that position of needing to suddenly try to navigate. And again, not to say that these things can't happen or that there can't be challenges in the kind of provision of services or the sustainability of systems, but I think it was a uniquely challenging scenario. And if there's anything that we can do, maybe we can't 100% avoid it, but take steps to try to protect against that. It feels like it is worth doing. Great. Well, appreciate that and appreciate you letting us, do this kind of download of a lot of the thinking and research that we've been doing over the last month or so with all of you. And as I said, more to come on that for the group, and look forward to diving even more into the detail and some of the decision points here, and hopefully being able to make some progress on this front during the session.
And if you could send these slides, I'd love to look further into a couple of these. That'd be great.
Yeah, absolutely, Mallory. It should, and I apologize because it was just before the meeting, but I did send a copy of them out to the group around 2 o'clock or so, I think. So they should be in your inbox. If you don't see them, just let me know, and I am happy to follow up if I left them off.
Thanks. I hadn't seen it yet, but thank you.
No, I completely understand. I would not have expected you to, but yeah, definitely understand. We move quickly and cover a lot of ground. So nice to have them available if you want to spend a little more time. And again, look at some of the links, or we did include the title and the information about that RFI response from DHHS, which I think is a really great read, as I said, for anyone who wants to dig in a little more. So moving on to the next topic that we had on the agenda today, it was just an update on legislative reports, which has been where a lot of our time and energy has been over the last several weeks. Just wrapping up a few additional requests that we had from the legislature that we owe back, in addition to the annual report that, as I said, we'd shared for review in December and have now finalized and made available. So the first of those is around main care eligibility increases in state level subsidies. Just as sort of a reminder, way back in 2022, the legislature had passed a bill that included some resolve language with sort of a one-time requirement or request of the office to study 4 different policy approaches to increasing consumer affordability. That resolve was subsequently updated, clarified by legislation that was passed, or a resolve that was passed in 2023 that asked us to prioritize the study of a public option health benefit plan and Medicaid buy-in program sort of combined, and report back on that in 2024. Given that the office hadn't been stood up yet, and that there was not a huge amount of time to provide all of this, and particular interest in those models from some legislators, particularly on the HCIFS committee. So we had produced and provided to them our public option report back in January of last year. But there were these 2 remaining models that still sort of were on the books that we owe a response or a report back about increasing enrollment in Medicaid and CHIP, including by increasing income eligibility levels and providing state level subsidies to populations on the marketplace. So I, in my mind, thought we will be able to put together some high level estimates on this to sort of, close out this requirement and be responsive to the committee. That turned into a 15-page report with a 15-page methodological appendix, because even simple estimates, especially when you're thinking about the marketplace where subsidy structures are so complicated, are hard to do in a simple way. So I shared a copy of this report with everyone on the email that I sent out just before the meeting, and really welcome those of you, especially kind of working in these spaces, to take a look at that, and would welcome comments. Would love to have them next week, just as we try and get this closed up to send back to the legislature. But I thought it would make sense to just do kind of a quick overview of our findings on this, or some of the work that we did with this group, especially for those who might not have time to kind of dig in and review the full report. We included a lot of background, just I think on current eligibility for programs and financing structures and things that are helpful. But ultimately, where a lot of our focus was on estimating the cost to the state to any of these models. That's for a couple reasons. First, our ability to actually estimate consumer costs is pretty limited. We're working with publicly available data that tends to be relatively high level. which makes it much harder to actually kind of do comparison scenarios. And clearly we do not have an actual model that allows us to think about behavioral economics and incentives. So we drew some high level conclusions on that, but the true kind of number crunching was really focused on cost. And that's also because, to be really frank, I think that that's where the challenges arise often with these proposals. Generally, it's great to improve affordability for consumers, but how to generate the financing, especially at a state level, to be able to do that is usually where the proposals stick. So we felt like that, given how broad and high level the request to us was, is a helpful starting point, also given the budgetary challenges that the state's facing. So the first scenario was focused on increased eligibility for MaineCare. And to try to just set some parameters for that or think about how to conceptualize it, we came up with 3 different scenarios, a little bit of a small, medium, large application of that would allow us to dig in and create some estimates. We focus specifically on adults from 19 to 64, given that there's been recent expansions of eligibility for children in the state of Maine. So children are currently eligible up to 305% of the federal poverty level. And obviously Medicare eligibility for older populations, kind of complicates things and tends to be the primary payer. So we felt like focusing on adults made a lot of sense from the intent of the resolve that we received. In the first scenario, we thought about just a narrow expansion of income eligibility for most of those adults from the 138 cap that's currently in law up to 150% of the federal poverty level. So our estimates that would include around 11,000 people newly eligible. The second scenario we thought about was expanding income eligibility up to 200% of federal poverty level. So that brings things up to 73,000, individuals. And finally going up to 250% of FPL, which tends to be kind of used, I think, as a marker for moving from low income to more middle income. And that would include potentially up to 131,000 newly eligible people. We did just a sort of a note on the populations, given that MaineCare and Medicaid programs broadly sort of don't have conditions on eligibility or coverage based on employer-sponsored coverage. This isn't limited just to individuals who are uninsured. It's really thinking about the entire population of the state of Maine that falls within those age and income levels. We wouldn't truly expect all of those people to move into MaineCare coverage, but in general, MaineCare is going to be, a lower cost option, even for people who might currently have coverage through an employer, for example. So we wanted to assume sort of maximum potential enrollment. This is a little bit small on our screen, so apologies for those in the room, but sort of the short version looking at that is costs for the really limited option on the low end of estimates for monthly costs for those enrollees, which is based on current MaineCare data reporting on their expenses, would be about $24 million annually for the state. That's assuming a federal medical assistance percentage that's consistent with the one for 2026 currently. There aren't a whole lot of states that have done these kind of expansions, but there is one example, the District of Columbia, that does have higher eligibility thresholds for adults, and they have been able to draw down federal FMAP. So the assumption and the conversation in states is that that would continue. I do think this is an area where changes in administration may change federal interpretation of law, or where things might be more challenging, but we assumed that there would be federal financial participation, although we did include the total cost of the scenario in these estimates, which at the very low end here you can see is $61 million. So that ranges all the way up to in even the low cost kind of per member per month cost scenario for the more expansive eligibility to $270 million annually in the state contribution piece. So that is just a brief kind of summary of the eligibility for MaineCare component of the report. We were also tasked with looking at state level marketplace subsidies and the impact of those and cost. This is an even more complicated analysis because we are thinking specifically about individuals who don't have an offer of affordable employer-sponsored insurance, since there are conditions of eligibility for APTC in those scenarios, for premium tax credits in those scenarios. So for this analysis, we really took a look at income ranges for individuals who are already enrolled on the marketplace in the state of Maine, and then specifically the uninsured population within given income ranges in the state, assuming that there wouldn't be much sort of movement of folks currently in employer-sponsored coverage into the marketplace. But again, this is certainly an overestimation of take-up, given that we never see 100% of eligible people enrolled, but felt like the most straightforward way to try to get a sense of the individuals. For this, again, we kind of thought about 3 different scenarios based on household income. So in the first, we thought specifically about targeting people between 150% and 200% of the federal poverty level. For everyone below 150% of FPL right now on the marketplace, given enhanced federal subsidies, their required or expected contribution for a second lowest cost silver plan is $0. So for most of them, not quite a $0 plan, given that some of our state mandated benefits are available, but almost all of those folks are going to be able to find a plan for $5 or less on the marketplace. So in scenario 1, we thought about essentially expanding that all the way up to the top of the 200% FPL range. So that's a group of maybe 11,000 to 19,000 individuals who would be impacted by that, though in our modeling, a few folks in lower income ranges would see a little bit of benefit because we would cover the portion of their premiums attributed to mandated benefits to reduce their plans to true zero. The cost for that at the state level would range in our estimates from around $3 million to a little over $5 million, assuming that ARPA subsidies are continued at the federal level. Those are set to expire at the end of 2025 and clearly a source of, or a focus of federal policymaking. So we did also include estimates for this work if the state sort of had to backfill ARPA subsidies. And what we found there was the cost under that scenario would be $80 million to $170 million because those ARPA subsidies significantly enhance affordability for that population. I maybe won't go into too much detail. Essentially, scenarios 2 and 3 bump up affordability up the income ranges, with the big distinction between 2 and 3 being in scenario 2, we would keep the cap or the expected contribution cap for households over 400% at the current level under enhanced ARPA subsidies, and in scenario 3, we would lower that even more. So scenario 3 is the one scenario in which the higher income consumers would see a benefit from the program. And in those scenarios, as you can see, pretty significant changes up to around 17 million at the top end for scenario 3 in state costs, even with the enhanced ARPA subsidies, and close to 200 million without. And that scenario, much broader kind of consumer impact of up to maybe 102,000 individuals impacted, because we're really thinking about the entire potentially marketplace subsidy eligible population in the state. It's a lot to digest. Yes, yeah, that's right, Kevin. Although it's a good point that you make, actually. I wouldn't say all within the individual and small group market, because in this scenario, we were only modeling individual group coverage, and we didn't anticipate any movement of enrollment between small group and the marketplace. So we're specifically thinking about those already enrolled in the marketplace, or I should say those enrolled in individual coverage, and those who are uninsured within the specific income ranges. So I know, again, I'm throwing a lot at you. This is the, oh, strange, sorry. Can you double check Kevin's permissions? It looks to us like you should be able to get on mic, Kevin.
Okay, can you hear me now?
Yeah, we can hear you.
Oh, great. Okay, thank you. Yeah, no, my point was by increasing the Section 1332 pass-through funding and enhancing Magera's ability to provide greater value to the market, it actually reduces the premiums for everyone in the individual and small group market the way it's merged today. So
Yes, I'm sorry. Go
that
ahead.
was kind of what I was after, is that there is that beneficial impact by driving up the amount of APTC coming being applied, assuming that it increases participation in the market, participation in coverage would mean more APTC. Therefore, that equates to greater spread between before and after Magera, which drives the pass-through funding, which then benefits everybody.
Yes, and I apologize. I saw the second half of your chat and missed the first, so I was
No, it's all right.
No, appreciate that. We did. I will take a look, and I think we can probably put a finer point on that argument. We had, at a high level, discussed kind of the broader market implications of each of these with the, sorry, I'll go back to the APTC slide, specifically thinking about increasing the size of the risk pool and maybe the relative kind of risk of the population enrolled. We had stopped short of trying to quantify that in any way. I just think that's beyond our capacity. Again, not really knowing what the risk profile of folks is to try to say what the impact would be. And again, so much unknown about uptake, and so much of that can depend on kind of implementation. So just beyond our capability. But we had touched on that, and I think may have briefly talked about that impact being applicable for the broader merged market, but I don't think we really specifically made the point around pass-through. So I'm happy to go back and take a look and sort of amp that up or put a little bit more focus on it in the draft as well.
Great, thank you.
On the opposite side. Oh, sorry, go ahead.
I was just saying, happy to help if I can lend a hand.
Great, thank you. I was just going to say, in terms of kind of broader market impacts from either model, we did also note in the scenario of increased Medicaid eligibility, though that is a good point to be really specific about pass-through on reinsurance from that as well. But, we had noted that could significantly reduce the size of the marketplace population and could have some negative consequences for affordability for consumers that remain in that market. So again, weren't capable of quantifying that, but had flagged in both of the scenarios that you can't sort of consider impacts only on the so-called target population for each of the models. It's really necessary to think about what the broader kind of market implications would be. So finally, on facility fees, I'd hoped to have a draft of this before today's meeting, and I'm just still making final edits, but I think tomorrow and certainly by the end of the week, we will have a draft to share with folks that we had discussed at a high level, kind of the substance and our approach for this report, which hasn't changed since the last time we presented. The one thing that I did just want to highlight was just recently Maine Health Data Organization released their updated annual report on facility fees, which is available on their website now. And one of the requests that was made to us and them from the committee was sort of working together on changes to data collection and presentation on this front. We have had a lot of really robust and interesting conversations with MHDO and with some stakeholders too, as we were working with the first round of data. We were able to chat with some hospitals and some carriers about kind of outliers that we saw in that data and trying to understand scenarios a little bit better. So some changes have been made to that reporting as a result of those conversations, including some information about the volume of claims in each one, since it's represented as percentages of payment. Originally, it was very hard to understand if we were talking about a large number of claims or a small number. So that is included, as well as some more detail on sort of the methodology used to develop the analysis. And specific information about occasions where there's split billing, meaning both a UB04 and a CMS 1500 claim form have been submitted for the same kind of episode of care or service. So kind of responded indirectly, but worked with MHDO to incorporate that feedback in response to the committee's interest. And then the brief report, which is actually briefer, it's not 30 pages long, is really about the second request where they had asked us to take a look at laws in other states and then have some discussion about how those policies would impact Maine and whether there should be recommendations. So more to come on that, but just wanted to provide a brief update, particularly kind of highlight and point anyone who is interested to the MHDO updated report. I think that is the last slide that I had, so I will stop sharing on here. Bring others back up again. And just check and see, as I said earlier, I feel like there's a pretty kind of clear, next step and plan for the next meeting, which is to particularly focus on this draft language, addressing market oversight. And in the meantime, again, welcome comments on the resolve on increasing affordability, and we'll share the facility fee report for comments and feedback before we finalize as well. But are there other kind of comments, concerns, thoughts for the next meeting? Anything that we didn't cover? Great. With that, I think we are done a little bit early, which hopefully folks always welcome a little bit of extra time back in their calendars. Look forward, and like I said, it works out really great given everything going on, that we'll see everyone a little bit sooner than we typically would. So in that first week in March on Wednesday afternoon at the usual time. We will see you again. Thank you all. Hope you have a good rest of your February. Hang in there.
Thanks a lot, Meg.
Thank you. Bye-bye.